Hey folks, this is Scott Weingart and this is an EMCrit We. Today we're going to talk about a new subspecialty in critical care training, which is cardiovascular or cardiothoracic intensive care. This is a niche subspecialty, just like neurointensive care has kind of split off from the mainstream and has really established a domain all their own due to the intense technology and specialized knowledge situations. So the question is, should that happen for cardiothoracic, cardiovascular stuff as well? I got contacted by two of the guests on today's show, Chase Donaldson and Brandon Wiley. Chase is a ED critical care doctor who did a internal medicine critical care fellowship and then specialized in cardiothoracic care. And Brandon was actually a cardiologist who went back and did critical care training. This is a nascent and a small group, but they are growing and it's becoming a thing within the cardiology world. And the two of them are part of a Cleveland Clinic fellowship that's an add-on after you're finishing a critical care fellowship in one of the other specialties, whether it be surgical anesthesia or internal medicine. So it's an add-on year for the really, gung-ho people that want to do another year after 1 or 2 years of existing critical care training. And then once they spoke to me about their fellowship, I wanted to get Trina Augustine on, who is the team leader of EMCrit. You've heard all her great stuff. We've been talking about valves lately because she kind of crafted her own within a 2-year fellowship at Emory. So we have a talk today about cardiovascular intensive care as a new subspecialty in critical care medicine. Now, this is a niche topic. I know a bunch of the general audience is not going to be interested. Just stop listening now if this is not your gig. But for the people that are interested, I think you'll be really interested because it's a great discussion. Let's get right into it.
All right, we'll start with the same question I always ask, which is something I ask all of you, who you are and what you do for the audience. And we'll start off ladies first. Trina, tell us. Most people should have heard you by now, but just in case.
So I'm Katrina Augustine. I am an anesthesia critical care fellow with a background in emergency medicine. I am currently completing my fellowship at Emory, and I'm super excited to join you guys today.
Chase?
I'm an emergency medicine background with an internal medicine critical care training. I am now at the Cleveland Clinic in the cardiothoracic ICU, where we are starting a cardiothoracic critical care training pathway.
And Brandon?
Yeah, so I'm a cardiologist by training, and I also did a critical care fellowship at the NIH. And my clinical practice is in the cardiac intensive care unit, and then in the echo lab at Mayo Clinic.
Love it. Love it. All right, I'm going to throw out a proposal to all of you to get us started, and you can tell me if I'm an idiot or I'm on the right path. I think critical care training right now is too fragmented. It makes no sense. It's idiotic, and it's not what's done in pretty much every other country. What do you think about the idea of 1 year of a consolidated curriculum for all aspects of critical care? And really, you could do it in 1 year, just general critical care. I don't care if you're a surgeon, a neurointensivist, a cardiac critical care specialist, or what have you. You get the same year as everyone else. And then the second year, they all probably should be at least 2 years, is a specialized training in things like neurocritical care or trauma or pulmonary disease, cardiac critical care, or what have you. And then everyone would be bringing something specialized to the table, but you could put anyone in any unit and they'd be able to handle their own. I'd love to hear your thoughts on that idea.
I can start. So first of all, I think that I agree with the idea of the kind of fragmentation of critical care. I'm just afraid that proposal actually will potentiate that. I really do think that 2 years of solid critical care training, mechanical ventilation, vasopressor inotrope management procedures is really necessary to master the physiology and the procedural repertoire you need to be a good intensivist. So I think that 2 years is absolutely essential. So if we started with, if we rephrase your proposal in terms of 2 years plus, I would totally love that. I just don't think 1 year coming out of a internal medicine residency, a neurology residency, even, internal medicine, out of emergency medicine. I just don't think that's enough to really be a master of critical care. And before you kind of further specialize and really find that more specialized niched area.
I'm going to push back and then I'll hear from Trina or Brandon if they want to add anything. But you do know that anesthesia and surgery are 1 year fellowships. I mean, they penalize emergency physicians by making a 1 year fellowship into 2 years, but they are 1 year fellowships currently.
It's just to respond to that. I specifically took an internal medicine pathway because I did not feel like 1 year was going to be enough. And I was very glad I did. And so I do think that added year really allows you to really grow those deeper roots in the field. So that's just my view on it anyway.
All right, Trina, Brandon, before we move on to the next question, any thoughts on that?
So I might have a slightly different, view. I was a critical care nurse for a while before doing this. So I came back, went to emergency medicine, and then I did a 2-year fellowship. And I chose a fellowship at Emory because I specifically get kind of 1 year of general critical care training and then 1 year of like kind of subspecialty, specifically cardiothoracic critical care training. Do I always think you could use more training? Absolutely. But I do think that 2 years, when you come in very focused and saying, look, I want to be a great, critical care intensivist. So I'm going to get that kind of comprehensive view first and really get that good training and then focus in on the specialty. It has really helped me. And I definitely would be, someone who'd be highly supportive of kind of a program where you have 1 year of general critical care and then you had that 1 year to focus on a subspecialty you're interested in.
Brandon, do you have any thoughts on this?
Yeah, I mean, I'm going to be honest. I kind of did what you're talking about. So I did a cardiology fellowship and then I went to the NIH, and the NIH was you do a year of general critical care your first year. So that's like, you kind of experience everything, you're in the SICU, you're in the MICU. For me, I'd already finished a cardiology fellowship. So it was fascinating in a lot of ways to do that, but it was a nice broad-based training. And I think, if you think about that next year you're saying is more specialized. Well, I just did it on the front end, right? So I spent that time, as a cardiology fellow. And in cardiology fellowship, we only do most of the time now. I mean, a lot of it's very procedural, but very outpatient based. So you only do maybe 2.5 months of CICU or CCU, but you develop that more a specialized skill set during that training. So there probably is a way to, I think the generalized training like you're talking about is great, and you need that. I mean, that's how you really start to think like an intensivist, right? But then the care that you develop, either if you're going into the neuro ICU or even the cardiac ICU, that can be done in a lot of different ways. And I don't think there's one way to do it. It's more just developing that instinct, that critical care instinct that you develop during some generalized training.
Our neurointensive care colleagues really have made, I think, the pathway to saying that in addition to these generalized critical care skills, there might be a subset of skills that are unique to that subspecialty. It sounds like, Chase, Brandon, you two are proposing something similar for cardiovascular critical care. Why don't you tell us a little bit about the thought process and what you've actually developed? Chase, why don't you start us off?
Yeah, so I kind of feel like you said neuro. It's you look at neurosurgery, trauma, and cardiac. They all came out of this surgical running management of both the operating room and then the post-operative care. And you've seen all three of those fields with cardiac trailing of a kind of handoff of that bedside intensive care to a specialist, to an intensivist. Trauma, I think, picked up on that earliest, and there's not a specialized trauma critical care pathway except for this way the surgeons do it. Hemorrhage is hemorrhage. There's not like a specialized technology or even specialized procedures for trauma by the time they get up in the intensive care. So it ends up being kind of belly trauma, head trauma. It kind of just it's kind of bread, not so I don't want to say bread and butter SICU, but it is a kind of a more generalized practice. Versus neuro, the technology is exploding. These specialized niche expertise you need is exploding. And cardiac's the same way. Specialized procedures. Transesophageal echo is an area that I don't think you can be a good cardiothoracic intensivist. You need that skill set. You need to be a master of pacemakers. Mechanical circulatory support. I mean, there are new devices coming out all the time. Some of which are getting smaller. Maybe even getting into the realm of the intensivist being able to place at some of the percutaneous VAD supports. It's getting close. So, and it might be even being done in some places. I don't know, but I feel like all of these fields came from a very heavy surgical hand, and now the paradigm's changing. I think cardiac's the last one to change, but I do think it's getting there, and we're trying to kind of lead the way on that.
Brandon, what do you want to add to that?
Yeah, I think it's well said. The coronary care unit, or the CCU, has evolved. And, at one point, the ICU care for cardiac patients was really revolved around acute MI. And it's different now. And, it's more of a hybrid unit, right? Where we deal with post-procedural patients, with percutaneous interventions, with clipping valves or whatever it is that we're doing, that the cowboys are doing in the EP lab with epicardial ablation and everything else. So, the patients have become more complex. it's much more heterogeneous in the CICU. And then there's more of a post-procedural flavor to it. So you have to understand a little bit about like surgical complications. That's an important thing. I think that's something you build in during your critical care training. And then the other thing now is with the advancement of percutaneous mechanical circulatory support, now you have these devices that you have to learn how to manage too. So, it's the ICU has evolved in general and the CCU has really evolved into a CICU. And it's just a different, there's just a different skill set that's required now.
Chase, why don't you tell me a little bit about the curriculum we've developed? And since in the vein of the beginning of this conversation, it sounds like you're adding this as a tack on to an existing critical care fellowship as an additional year. Why don't you tell us a little bit about that curriculum? And then I want to hear from Trina about the one she ad hoc developed at her own place.
Sure. So it's a plus 1 year. So we're looking for people from all across the world to come in, having completed some sort of critical care training. That could be, if we're trying to keep a broad scope. We have 4 surgeons in our critical care practice, CTA folks, internal medicine folks, ER folks. So we love, and we've all benefited from the multidisciplinary ICU approach. That is just, that's been transformational for me in my careers, is having colleagues that have this niche expertise in things that I don't. So I've learned a ton from those people. But the curriculum is very much focused on kind of the post-operative cardiac patient, and less so like the CICU stuff, but post-surgery. So, very close relationship with surgeons. So the kind of bread and butter cases, but then also the mechanical circulatory support. If you look at, there are almost twice as many VAD programs in the country as there are critical care programs when you look at Pullman and everything. So there's a lack of opportunities for training that people to get exposure to this. And even when you do get exposure as a fellow, it's often a very hands-off environment for the fellow, because just a variety of reasons, but there's a very close working relationship between surgeons and intensivists that trust is important. And having, somebody float in there for a month is sometimes unpalatable for the surgeon. So it's sometimes hard for, even as a fellow that's really, go-getter, to get their hands on the sort of procedural hands-on, even just the clinical autonomy to manage these patients. And so we're focusing on that mechanical circulatory support, both VA and VV ECMO, the cannulation aspect of it. Transesophageal echo is going to be, a specialized area. The expectation is that people would be able to complete the fellowship and pass the advanced PTE exam as a testamer. That's one of the barriers to all this. There's still some siloing in the echo world. The critical care echo boards but they definitely aren't. I don't think they're sufficient to get you that next level to take care of the post-cardiac surgery patient with all the nuances of that care. And then heart and lung transplantation is another big area that is also is niche, but programs are growing and programs, and the job market is demanding this. You go and look for critical care jobs, and all you got to do is look, if it was academic or if it's private, they're all looking for cardiac experience. They want this before they're going to hire you, because a lot of, unfortunately, on-the-job training goes on post-fellowship. I feel like cardiac's one area you can't walk out of fellowship and be able to perform independently well without, some pretty good somebody at your back for at least a couple months to get your feet wet, which is not the case, I don't think, in a medical ICU or some other areas. So we're trying to just bridge that gap and have the curriculum around those sort of echo, MCS, bread and butter cardiac, and then, heart failure with that. So
I love it. Trina, you've kind of, as a go-getter fellow, have crafted your second year of your anesthesia critical care fellowship to pretty much mirror a lot of what Chase and Brandon are talking about. Why don't you give me your thoughts on specialized training in cardiovascular critical care?
Absolutely. So obviously this is something that I felt very passionate about. And when I was looking for fellowships initially, I kind of interviewed all over the US and was looking for a program where I was going to be able to get comprehensive, critical care education, but also get that focus that I wanted on kind of cardiothoracics as a subspecialty. One of the things that I found kind of with Emory was I was able to make a little bit of that ad hoc program for myself. So just to give you guys an idea of kind of how my 2 years looks here, I do 1 year of basic kind of general ICU training where I'm spending time in like the medical, surgical, trauma ICUs, doing the classic electives that a lot of us fellows would do, everything from nephrology to infectious disease, critical care POCUS, all of those things. And then my additional year, which is somewhat interspersed, my first and second year aren't like necessarily calendar years, but my second year is much more cardiac, thoracic heavy. I do a total of like 6 months of cardiothoracic ICU, 1 month of like a heart failure ICU. And then I do like 6 weeks of echo training. I do a month or two of specific ECMO training. I do a time where I actually spend a full month in the ORs with the cardiothoracic surgeons. And I actually do cannulations for ECMO throughout my entire time in the CICU. So while I'm in the cardiothoracic ICU, we cannulate those months. So I do remote ECMO cannulations all over Georgia and the surrounding states. As a first year fellow, I think I've done about 16 or 17 cannulations already in this first like 9 to 10 months. So it's a very hands-on program where we really, as fellows, get to be super involved. You get to know your surgeons really well. I think I text almost every one of the cardiothoracic surgeons at this point. I can run down to the operating room, follow the cases so I can see what's actually happening. So I can, kind of better anticipate the complications that I'm going to expect in that post-operative course. Overall, I think I totally agree, Chase. I mean, I love how you described your fellowship. I think that what you guys are doing is absolutely incredible. I know that that's going to add 1 year. And I think that that's probably not at all a bad thing and probably gives people the most preparation they could possibly get. But I will say a fellowship like a place like Emory, where you can get those 2 years in one, it is really nice to try to condense it. So that's one of the things I've been trying to do here.
I want to harken back to something Brandon mentioned. And Brandon, you're a unique person to answer this because it's very rare in the cardiology field for someone to go back and do a critical care fellowship. The CTICU in most of the big academic centers I've worked in has been a very intensivist-driven, very cutting-edge care type place. It has to be. The patients are so sick now that are coming out of these ops. The CCU generally has been a unit that's kind of lagging, I think, in some ways, in many places. There are places for post-thrombolysis or PCI patients that are high risk. They might have an Impella placed in, but if I put a undifferentiated cardiac arrest patient there and it turns out that they're not just a simple STEMI, I really have fear for the care they're going to get. And in many places, they'll actually consult the MICU attendings to do vent management. That's always really struck me as an untapped potential for really advancing care in a hospital. All CCUs be managed by intensive care, with cardiology being the consult service that will, or the main team that will see their patients every day, much like a SICU model, where there's an intensive care doc actually being the primary caregiver. And that intensive care doc could absolutely be someone like you, Brandon, who went through critical care fellowship. But I'm really leery of them being managed on a critical care stance by cardiologists without critical care training. What are your thoughts?
Thank you for that question. I mean, I just have to thank you for giving me the opening. When I elected to do critical care training, there really wasn't, a path. There weren't people like myself, and there's a bunch of us now, really who got into this because of exactly what you're talking about. When I trained as a cardiology fellow, there were a lot of times outpatient cardiologists that were rounding in the CCU. And I trained in New York City in one of the large hospitals there, and there were really sick patients. And, and just again, the demographics of the CCU has just changed, right? It's no longer like a single organ system problem. It's multi-organ system dysfunction or failure, right? You have acute on chronic heart failure with requiring CRRT, maybe VT storm, all these different things. They're getting intubated. I mean, so I looked at it as an opening for myself for a career path, and the career path has just sort of opened up in the last couple of years. The American College of Cardiology has just recognized cardiac critical care as a section, like a member section, and there are programs growing. To get to exactly what you asked is like, what's the perfect model of care? I think there's not a one size fits all. And you have to look at the centers, right? So like a large academic center like Mayo Clinic, for example, that's where you are going to have people like there's 5 or 6 of us now that are double boarded. And because we have a complex mix of patients. We have congenital patients. We have patients that are kind of crashing a cardiogenic shock. They're going to be worked up quickly for a transplant. So they need people like us. But, in other settings, maybe more community practice settings, you may have a model like you're talking about where you have an intensivist who's really, the minute to minute care of patients. They're taking care of those patients. And then they're working in collaboration with the cardiologist. So I think that you have to have like a flexible model, but you do have to start to build out a pipeline of people, of cardiologists who've taken an interest in this, who can then lead units in more advanced centers. So I like everything in critical care. I think that, you have to fit the model to where, to the patients that you're taking care of. And there are units now that are, Chase works in a cardiac surgical ICU. I've worked in hybrid units where it's a CCU and a CTICU all together, right? 50 patients, mixture of me and maybe a cardiac anesthesiologist or the care providers. And we have overlapping skill sets where there's certain things that I do that the cardiac anesthesiologist doesn't do, and the flip side, right? So the anesthesiologist is going to intubate the patient with critical AS who's crashing. It's not what I'm going to do. But, I may be the one that manages some of the hemodynamics and drops the TE probe and helps make some of the more nuanced decisions in the care plan. So when you have that sort of collaboration, it's really exciting, and you can grow and learn from each other. So I think that there are opportunities like that.
I love it. That's such a perfect answer. One of the problems I dealt with in my previous shop was I was starting an ECPR program and there was no landing zone for my patients. The NICU had no experience with ECMO. The CCU had no intensive care and no experience with ECMO. The CTICU obviously did ECMO extensively, but could not handle all the other aspects of it. But the real fear they had, and the reason they would say no to many of our patients for going on pump, was that it would take up a cabbage bed. And it was legitimate. It drove me nuts, but I completely understood their viewpoint, because if they didn't have a bed for their cabbage patient and that op got canceled, that would not sit well with the hospital. Where should an ECPR patient go? Chase, why don't we start with you?
Ooh, that's a tough one, because we started with that same problem. We have a 94 bed cardiothoracic ICU, so 94 beds filled with surgical patients, and it's insane. But we have very much struggled with the same. And so where should they land? A lot of the times the question is, what the source of it is. So is there going to be something that can be? Is this patient is going to need a cabbage? And it's kind of going to be, worked up as a pre-op and then get their cabbage, and, we'll go from there. Or is it just kind of undifferentiated? In which case, I think most cardiothoracic ICUs have, multidisciplinary intensivists now that can manage the global scope of what's going on with them with, some neuro help. But I think that it really is an area that potentially could be managed in any of those areas. I think we're getting to the point where intensive care, it is getting increasingly specialized in some areas, neuro and cardiac, think being the most specific, but bread and butter, mechanical circulatory support with ECMO, just kind of waiting for some little bit of myocardial recovery while all the other things are going on in the background. I'm hoping that the fellows coming out of these coming years are going to have the experience, so they will be able to do that. I'm a little concerned we're not going to get there, and we're going to continue to have that very same ownership problem that you're describing. And so my answer is a little bit idealist, but I do think that's going to be a perennial problem going forward, I think, in the next few years until we figure this out as a field.
Let's hear from Trina what they do at Emory, and then Brandon, if you want to weigh in on anything, I'm happy to bring it to you. Trina, what do they do at Emory? Do you have any CPR program going at Emory?
So we are kind of currently in the process of creating one, but we are doing ECPR cases, and I just did one with one of the surgeons a couple of weeks ago. So right now, those are coming to our CTICU, and most of that is because, it's basically the only place at Emory that RBA ECMO patients can go. And it's not just the component of the physicians able to care for them, but I also think we have to remember you have to have perfusionists or people who are trained to do that, as well as nursing staff who are comfortable. And I think especially in kind of with the nursing shortage that we're seeing right now and having a lot of, even traveling nurses coming in, I think it's really important to have team when you're caring for these patients. And, it's physicians, it's perfusionists, it's nursing. So at Emory, it has definitely, all of those patients are coming to the CTICU where we are more accustomed to seeing these patients.
Brandon, you seem like the ideal person for me to send my ECPR patients to, maybe with a little neurointensive care consult on the side. What are your thoughts on this?
Well, I think, this is disruptive technology. and it's just changing the landscape of the ICU. I don't know if I have the right answer. I would say that, a lot of it has to do with the resources, as was said before, that are in place. There are, when I was working in Minneapolis, they had nurse perfusionists. And that allowed, for a little easier to care for the patients where they're going to go. And all the patients were actually cannulated in the cath lab by the interventionalists. Every interventionalist could cannulate quickly. And they had a nice program for that, but they were cared for in a multidisciplinary way. So I think that, I think this will evolve. What the right answer is, I'm not totally sure. I don't know if we're going to move to a place where we just have actually an MCS unit, that is, again, multidisciplinary in the practice, right? You may have a cardiologist, or you may have advanced heart failure therapy physician that's a part of it, consulting with then a more of a intensivist there, for the minute-to-minute stuff. But, it depends on kind of where you're located and what the resources are. And I think, again, every place is going to kind of look at this a little differently.
All right, my friends, what have we missed that you guys want to get out there? Anyone pipe up?
I think an interesting question. There's just like it happened in the building homes. The open concept is hot. It's what it's what's the cool thing to do. But it's almost gets to the point where things are so open that maybe we want a wall here or there. We want a little bit of privacy. And I feel like critical care is we're doing that. We're knocking down some walls. I think one interesting wall that remains, and Brandon, let's get your thoughts on this, is that cardiothoracic, the surgical aspect of it, versus the CICU. There's that wall there. And there are places that, have, like we talked before about, there are these hybrid units, and that you can kind of have that pre and post operative role. And I think it's actually really great, but that is I think a continued silo or barrier within critical care. And the wisdom of breaking down that wall, I continue to ask myself that question, whether there's wisdom in that or not, or if it may just be institution specific. So I kind of like to get people's thoughts on that.
Yeah, I mean, you make a good point, and I just, it's tough. I think that my ideal vision of a cardiac ICU or a cardiac intensive care unit is a hybridized unit where, if a patient comes in with a big MI, and they're managed and they're go for a cabbage, they'll go for the cabbage and go back to the same room. And you don't have these handoffs in care, this fragmentation that exists. Unfortunately, within cardiology, we've been quite protective of the CCU, right? That's just been something that cardiology is not willing to kind of cede ownership of. And I think that the cardiologists have to look at it in a slightly different way. It's not ceding ownership, but it's really investing in the unit and growing the unit, and allowing it to become a place that takes care of sicker patients and in really a collaborative way. So, I would love to be working with, in my unit, I would love to have some EM trained physicians that I could learn from, right? That would provide a skill set that I can't. Even with my critical care training, I don't have that skill set. I didn't spend 3 years in an emergency room, whereas I can see the need for that in my unit. And I think that, the silos are terrible because you stop growing as a physician, and it really limits what you can do with care. So I look at cardiac intensive care as really a great, it's just this great symbol of what critical care could be, where, I'm speaking with you guys. None of you guys are cardiologists, but you have a great background and great training. And I would love to work with all of you. And I would love for our cardiology fellows, to be interested and to look at this as a path that they could go, where they could go train in critical care, like I did, spend time in trauma and resuscitating patients and doing that sort of thing. And then, someone's like, oh, Brandon knows how to do an echo. Can you echo this person? It's like, oh yeah, absolutely. What do you want me to do? You want me to put a PA catheter in? I'm happy to do it. All of a sudden it becomes exciting, and you're really taking great care of patients, and because those resources are right at the bedside. So again, I look at the CICU as this paradigm, this model that we can use to really look at the evolution of critical care in the United States. And obviously I'm biased, but that's my view.
I love your view. I love your vision. Trina, finish us off.
Brandon, I absolutely love that. That was said so eloquently. I will tell you that my colleagues, I get to spend a lot of time with a lot of the cardiology fellows, including acute heart failure fellows. And I try to spend as much time as I can in the cardiac ICU. And here it's a little siloed at Emory as well, which makes me so sad, because I think the amount of learning that happens when we work side by side is just absolutely incredible. And it's so exciting to see all those patients that are in the cardiac ICU kind of pre-transplant and then care for them post-transplant. And I think having, we all get so excited, both the teams taking care of them pre and post, and having them in that perfect big ICU where you could have pre and post, they come back to the same room would be amazing. I'm with you. I think the future of this field would just be so incredible if we would be able to, have that teamwork and work together like that.
That's the perfect place to stop. Chase, Brandon, perhaps you guys could put the links to your program, and I'd love to have your curricula as well. And people now know it's out there. Hopefully, if they're interested in this, they will get in touch. All right. Yeah. I can't thank you all enough. This has been amazing.
Thank you.